Hi, I'm Liz Aiken, WMTV. This is In a Heartbeat, the studios of the Grosse Pointe War Memorial. We tape in Grosse Pointe Farms, Michigan. This is part two of a show that is so fascinating that we really could hardly get the cameras going because we were talking so fast and having so much fun and laughing. But I have to do the second show, but I want this show to go on for 3 days. So what are you going to do about that one? All right, we're going to talk fast. Again, listen up. Don't leave the room for anything. Turn the show on again. Let somebody else know if you think it's a show of value to them. I can't imagine whom this would not impact. All right, my guest is Dr. Bruce Baker.
Thank you, Liz.
Your specialty is, you call yourself an addictionologist.
Actually, that's in debate. The American Society of Addiction Medicine still can't decide whether the terms are addictionist or addictionologist.
Okay, all right. And we didn't even get to, we were laughing in the break after the first show that we hadn't even gotten to some basic stuff. Like, guess, where do you think the guy works? He drove here from Grand Rapids for these shows, and this has been so cool. The company is West Brook Recovery Center. Tell me about this.
Westbrook Recovery is a drug treatment center, and we have outpatient programs, we have evening outpatient programs, we have counseling, and we also have a pretty unique residential situation in that when people come to us with drug or alcohol issues and they require residential treatment, they actually live in apartments. They don't live in a structured environment that provides them with food and clean up after them. They have to do their own cooking, right. They have to do their own shopping, they have to clean their own apartments, and they live with other people with similar problems. And so really what we deliver at Westbrook, when they go back to the apartments and discuss with each other in a more relaxed way, that's where a lot of the treatment is coming, is from other patients with similar problems in real living situations. Because it's so difficult to take someone and put them in a residential facility where they go to a cafeteria and they finally get their life straight, and then all of a sudden they're released, but now they got to go shopping, they got to cook, they got to clean, their activities of daily living. We incorporate that from day one.
So you really, because when they are in a setting that is, like you say, so controlled, they're almost robotic in what they do, and then they leave and they're in shock.
And
so
they're all on their own.
Top of that, they still need something, but they don't even know. Right, they're on their own. They don't. Besides which, when they are on their own in these apartments, then they are learning day by day to replace their initial urges or whatever brought them there with the better way to think about their own lives, and as you say, from talking to other people, but it's still in a more normal environment.
Absolutely.
To then hit the road and really put that into practice in a likewise more normal environment. And it's not successfully, hopefully.
And it's not for everyone, because if an individual cannot stop using, then they have to go to a more structured environment that is basically a lockdown facility where nothing comes in, nothing goes out, and they're not allowed to leave.
I was going to ask you, how do you then, not police, I hate that term, but how do you know that when they go back to their apartment each night that they are not using?
Well,
how do you know that?
We have individuals therapists that live in the apartments, and they have their own apartment. Usually when a new client comes in, they will go with the individual, the male, or if it's a female, with the female, until we know they're stable, and then they can go with the other individuals. And people are ready, and they're ready to change after living with our therapist for a week. And they get a new perspective. But the first thing people need to do is to quit using. And Will Rogers has the best quote. He was the cowboy philosopher from Oklahoma. And I love the quote. He said, if you find yourself in a hole, quit digging. And that's really initially what we try to teach people, is stop making it worse. Let's just stabilize it, and we'll talk about how to deal with the rest of life as it comes through.
So when you see a patient, how do you determine which ones, it's like I have like 500 questions here at the same time, but how do you determine whether you think they're going to be successful? Is it something you can determine, or is it just you do it and it's a crapshoot, and what is the difference for that patient?
I wish it was predictable, because then you would know who to spend the enormous quantities of time with. But I can tell you, being around this field for the past 10 years, and the people I work with have done it for 20 and 30 years, it's unpredictable. You just don't know, so you still have to deliver everything as though they're going to get better, because if they're willing to stay for 90 days or greater, their chance of staying clean and sober, no matter the drug, approaches 80 to 85% at 2 years.
Wow.
But at 28 days, which most programs are, and now because insurances aren't covering much of treatment, we're looking at 9 to 14 days. In 9 or 14 days, anyone who's drinking is just waking up.
Right.
Anybody who's been on a meth binge is just being able to sleep now, and they're discharged. And they're just not picking up what they need.
It's a gruesome thought. So it's programmed for failure, depending on how intense or what the drug is, before they're, like you say, even waking up to even take in what's happening, and there's a chance to even think about wanting to stop digging.
Right. But the first point is get them to stop. Then we can stabilize them and allow them, by the time they stop using and people become more cognizant, now here come the consequences of use, whether it's a bankruptcy or a loss of a practice, or their spouse left them, or they've been arrested, now the police want an arraignment. We help people deal with that so it doesn't squash their recovery, because there is no obstacle that can't be dealt with. Really, there isn't.
Say that again, because that is very hopeful.
That people, I'm not sure I can say it again.
There is no obstacle.
There is no obstacle. People can get better, and that's part of what we teach people. It's not religious, but it's a faith, and it's the faith that it's gonna work. And sometimes in early recovery, I have to tell you, that's all you get, is just a little thin strip of faith. And if you hang on to it, and you wait long enough, and you follow direction, it's going to get better. It's getting people to hang on to that little tiny piece while we can gather our forces. The other part of Westbrook that is unique is we have Family Day.
I was just going to ask you about that.
The family suffers just like the addict.
Yeah, you got it.
They are the consequence.
Yeah.
And there's lots of issues with husbands, wives, children, other relatives, mothers, fathers. We bring those people in, but not until that patient is ready. That's not anything you want to do when they first arrive. We need to get them so that they can listen to it and process it accordingly. Not just listen to it and feel bad. We need them to listen to it, help them make plans, and go forward and try to heal some of those rifts. So how long do people stay in treatment? Everybody's different. We're used to, as a society, this issue of addiction, chemical dependency is so pervasive. It is 1 out of 3 people have a problem with drugs or alcohol at some point in their life. That's why it is such a joke to call a war on drugs. That's like calling a war on civilization. This is who we are as human beings, and we need to deal with it responsibly. And this is where treatment comes in. But we've got to get people there. How long is treatment? Well, it depends. If their wife is divorcing them or their husband's divorcing them, they have no more money, they have no job. Is this the person who's going to get out at the first opportunity? We try to keep them there until we are certain that they have an established program that's reliable, and most importantly, the resources to reach out and ask for help. One of the hardest problems we have, especially treating healthcare professionals and lawyers and judges, we don't like to ask for help. Everybody can do it on their own, and that's difficult.
It's true. When you are dealing with that high level. This is crazy. And you know, it's so funny because the phrase that keeps coming back is a barrel of commerce. And everything you're talking about, because we have, as we were talking about in the first show, that there's so many things out there to use, to choose from for whatever, and it's multiples of maybe the same basic drug, but multiplied so many different types, as you even showed in your drawings. And they're all commerce. It's all commerce.
And look at benzodiazepines. Yes, of all the drugs, if you were to ask me what drug is becoming more problematic now, and this also happened in the 70s. It is so interesting that our amphetamine epidemic was the 50s to 60s, the stimulants, and what was the 70s? That was the Valium era, the tranquilizer era.
Yeah, you're right.
And you will find, and that following these surges is just the opposite, almost to counteract where civilization went to during that time. And the benzodiazepines, Valium was the first one. Well, actually, Librium was the first one, and the gentleman that developed it, of course, was a chemist. Anybody who's a chemist, I gotta tip my hat. And he was an Austrian chemist, came to America to develop a tranquilizer. We needed a tranquilizer. The only one that was out there wasn't very good. And so they looked at a class of drugs. 2,200 different compounds were examined by Dr. Sternbach. Not one of them worked. What they do is they make these compounds just like they synthesize the designer drugs for the phenethylamines. They did the same for the benzodiazepines. And he developed, he said, I quit. He said, 2,200, I'm going home to Austria. I've had enough. Well, his lab assistant, another typical discovery in medicine, said, what about this one? He says, I've had enough, I'm leaving. Well, the lab assistant sent it to the pharmacologist, and that drug is now known as Librium.
Oh, wow.
And like every good scientist, he tried it because you would not release it until you try it yourself. And he said he did not like Librium. He didn't think there was a market for it because it made him so depressed.
Oh, my gosh.
And here we are today. We have a whole assortment of benzodiazepines, Xanax being the ultra-rapid. People use it for panic attacks. The problem is, again, we talked in the first episode, what makes a substance addictive? The rapidity of onset. You take a Xanax, or as my patients call them, Xanny bars, and within minutes, you feel different. Well, every time you feel anxious, what are you going to do? You go for the Xanny bars. Well, then they have other benzodiazepines with longer action, and like Ativan. Now, Ativan is still has abuse potential as well as Klonopin, but it's not as abusive and it's not used as often as Xanax because Xanax really changes your behavior so quickly. Of all the drugs to withdraw someone from, there's only 2 drugs that are dangerous to withdraw from. One is alcohol, second are benzodiazepines. And what do we see in treatment? Benzodiazepines and alcohol act on the brain identically. Functional MRIs, you can't tell which is which. And so what people do is they'll say, well, I don't drink during the week. I just drink on the weekends. So what's your problem, doctor? And then you find out that they're eating Xanax Monday through Friday to get to the weekend. So they're actually treating their brain with a similar drug. It just comes as a prescription.
So to get people out there, what about the deal that if somebody's on Xanax and they're using it, pretty consistently, and then they abruptly cease, or for whatever reason, you can go into a psychosis.
You can have a seizure, which is even worse because that can cause death.
That's exactly right. People have no clue about it. People do not know. They think this is a simple drug that helps, but they have no clue about the seriousness and the catastrophic consequences.
And the problem with the benzodiazepines, you don't smell like alcohol, so it can be a secret for a long time. Nobody's going to know. The dose goes only one way. The tolerance to this group of chemicals, and I'm referring, these are chemicals.
Yeah, they're chemicals.
Let's get rid of the word drug.
Yeah.
These chemicals have a built-in tolerance. And people will go to their doctor and they'll say, I'm anxious, I should say healthcare provider these days.
Yeah, healthcare
You go to your
provider.
healthcare provider and they say, well, here's a 1/4 milligram of Xanax, try it twice a day. And sure enough, they come back in a month and they say that was very effective, but it's getting a little bit worse. So they up the dose. And then they come back a month later and say, that was really helpful, but I got a lot on my plate right now, a lot of stress coming in. Well, and pretty soon, the doses come so high and so fast that you're not even getting relief from taking the high dose, and that's when people go out and buy it off the internet, get it from their relatives, or the most common is the medicine cabinet raid. And this is happening during open houses in the Grand Rapids area, that people are getting their medication stolen during open houses because...
Wait, back this up. People are getting the medication stolen at the open houses of
their home that they're trying to sell, because
On
all
the
these
general
people,
market, I never.
of course.
Oh my God.
And I can't tell you the number of patients, more than a dozen this year alone for me, who called me up because their Suboxone was stolen during an open house. It is a known entity, at least in our area, that that's a way that people can get their drugs. Just go to open houses. You never think of
Wow.
emptying out your medicine cabinet or
Right.
the drawer.
So that's something then to just think about when you are having an open house and you assume people going through your home are going to be going through your home for straight up reasons that they state, but be smart.
Pretty amazing.
Yeah, it's just, I'm like speechless even thinking about that one. And it goes so far beyond the commercial, and we talked about that before, where you see the kids, you know, raiding the parents' medicine cabinets. And the parents know things are missing, but they're still just stocking it.
Or
Beyond what it should be, like the aspirin, the small, low doses ibuprofen and Tylenol. And even that stuff you got to be thinking about if you have too much of just the most basic. Bleed out, trash your liver, trash your kidneys. I mean, the most basic. In the right dose is one thing, but
you know, and
You
as
must
as human beings, if one is good, three has to be better.
it's got to be. Right, that's exactly right.
And believe me,
Holy cow.
drug companies and pharmaceutical companies and over-the-counter producers like that.
A barrel of commerce.
It is.
Holy mackerel. Okay. If you are just tuning in, I'm Liz Aiken. This is In a Heartbeat. Studios at the Grosse Pointe War Memorial. I am having a crazy cool conversation with Dr. Bruce Baker. I wish we had hours to just keep talking about this stuff, because there, literally even every drug has a story to tell that is not just a story of holy cow, but a story where people can learn from. But I want to talk about one that is scary, is, you know, for every mom or dad who has a daughter, and that's the date rape drug. What is the deal with this garbage?
The drug that the press has talked most about is called Rohypnol, which is another benzodiazepine.
Okay.
Very similar to Valium and Ativan and Xanax, but it's a designer type drug in that you really have no memory and you function but don't remember it. And Rohypnol is the trade name, but the generic name is flunitrazepam, making it one of the benzodiazepine family. It comes as a blue pill, and what parents should be telling their children, and even for themselves, is if you are going to drink any place, make sure it is a clear drink and not a blue drink, so that you would be able to see if anyone added anything to your drink. But the most common date rape drug, by far and away, by thousandfold, is alcohol. That is the #1 date rape drug in the world. It's just not as elegant and dramatic as the Rohypnol.
It's not, yeah. Except there's nothing, you know, the pretty martini or the whatever, and then it doesn't have the same effect.
And
This is so
in my
scary.
business, it is always hard to remember that the majority of human beings drink responsibly, they take their medication as prescribed, and they do well. I get to see the people who don't. And I always have to remember that the majority of people actually do well with these. But the ones that don't, lots of problems. And you've heard of the Halcyon defense. Have you ever heard that?
No, tell me this.
The Halcyon defense occurred, it was in the 80s when Halcyon first came out, and a woman murdered her husband. And I don't know whether he deserved it or not, but we're not going to, we can't do that. We can't go there.
We can't go there. Right.
But she claimed that she was taking Halcyon and that she had no memory of it and she wasn't responsible for her behavior, and she got off. Because she was in a fugue state and has no recall of the event.
Right. It's crazy.
So it's called the Halcyon defense.
Halcyon defense. Wow. This is an educational.
And Halcyon,
I felt like I came out of a cave and I'm going, what? But this is fascinating.
Halcyon was actually removed from the United Kingdom as a drug 20 years ago. We still use it here in America.
Yeah, I remember that. Right. All right. I want to get to something that is so common for all of us. Anybody looking for a job anybody who's going through some form of, interview process, that part of that interview process is drug treatment. Drug screening, thank you. Drug treatment. Yeah, so the medical, when you were saying you're a medical review officer, I said, what does this mean? What does this mean you do? And then the drug screening, this is fascinating. So tell me about this. Because it impacts almost everybody looking for a job. Almost everybody.
You and I, when we first looked for jobs, we never had to do a drug test.
No.
This really came about in the 70s with Ronald Reagan, who basically saw that the people coming back from Vietnam were impaired. That there was a lot of heroin use, there was a lot of really potent marijuana and hashish from Southeast Asia. And his purpose was not to punish anyone. His purpose was to lend a helping hand. If you read the executive order, I think it's 12574, and I'm pretty sure that's the numbers, but don't quote me, that it says to lend a helping hand to those in need. And that's when drug screening came in. When they first wanted to do drug screening, alcohol was left off, because everyone drinks alcohol and it's legal, it's just going to cause problems, until the subway driver in New York, I think it was 1978, was drunk and 12 people were killed. That happened at the same time he was passing this law, and then it was truly a no-brainer that the government had to get involved and include alcohol testing as part of drug testing. And that became more prominent because the government said any company that has more than $25,000 of contractual work with the U.S. government, again, the U.S. government, the largest employer of the country,
yes, exactly,
has to provide a drug-free workplace. It's mandatory. And that's when we started to see drug testing in the private sector. Up until that point, it was just federal drug testing.
And it used to be a blood serum.
That was the original intent.
Right.
And when they were on the Today Show, Donna Smith from HHS tells the story that they had their representatives, because they wanted to do blood testing, because you can't fake it, you can't buy fake blood like you can urine, and it's all done in front of someone. Well, the gentleman on TV took a blood sample from one person, went to the other, and got so flustered from being under the lights and the cameras, used the same needle. And at that point, the government said, we are not doing any blood testing, we're going to do urine testing, and we're going to be doing breath testing. Now, recently, as of last week, the federal government has now approved saliva testing. And this is brand new.
And this is being actually taped in August, so a while ago for now, when this is airing now. Saliva testing.
Saliva testing. Now the science is so good for all these drugs of abuse, so that you can't buy fake saliva. It's done in front of someone. Yeah, exactly. So that no one can object to have to go to the bathroom and show their privates if it's an observed specimen. It's all done right there. And
how sweet is that?
But now there's a whole industry building up on how to use certain products so your saliva tests negative. Oh my God. Just like there's a multi-billion-dollar industry to go around urine drug testing. And hair testing is also, drug testing is, it's so easy if all you're worried about is positive or negative.
Yes, and that's a whole shindig right there.
But this is where a medical review officer comes in, because as you know in life, as we get older, nothing is right or wrong, positive or negative. There's exceptions.
Not that easy.
And for any employer who's hiring someone, an employer has no right to know. It is against the law for them to know what medical conditions you have and what medications you take. That is against the law. So what companies have done, they need an intermediary to look at the employee or potential employee and look at their medical records, look at their drug screen, and determine whether, if it's morphine in their urine, whether that morphine is validly prescribed or not. So the company will get from the physician who's doing the physical and the MRO who's doing the drug screen, yay or nay. Yes or no, and that's it. But the company does not get to know any details.
No, we've got about 2 minutes left. The interesting thing is that then if it's positive, then you call the person.
I call the person to look for alternative explanations.
The person whose specimen
Correct.
tested positive.
And my conversation with that person is not a doctor-patient relationship. I explain that right up front. And I am truly looking for alternative causes of positive drug screens. Whether it's a prescription that is valid, that's fine. If they've traveled out of the country and may have taken in something from another place and there are contaminants.
Inadvertently or whatever.
Right. And it's something that we need to take into consideration. As a medical review officer, the problem really comes in, the biggest problem, the truck driver, and truck drivers in this country are tested 50% a year. Truck driving in this country is better monitored than anyone else. And it's the truck driver who comes in and he's positive for codeine or Vicodin, and he says, he or she says, I had back pain and I used my wife or my husband's.
Ooh, right.
And then what do you do as a medical review officer? Because it's a job and they're going to lose it, and they may lose their career over it too. Over going into the medicine cabinet and taking 2 Vicodin. And it is up to us to make that determination. What do you want to do? Knowing that if they get into an accident a year from now on drugs,
the company's liable.
And so am I, because I said it was okay.
Right.
So it becomes very sticky, and then you can get into the fact that you can go to Canada and buy codeine without a prescription, bring it back to America, test positive, but you have no prescription for it.
Oh my God.
It can, again, you just want to know whether it's positive or negative.
Yeah, exactly. All right, we have literally, Dr. Baker, 1 minute left, period.
That was only 5 minutes.
I know. There's something wrong with the clock in this joint, I'm telling you. So in 1 minute's time, what can you think to hit on that you would like people to really, like the takeaway, as they always say, the takeaway?
That drug abuse, drug dependency is part of our civilization. That it is not, in most cases, a moral issue. Almost in all cases, it is an exposure. There's a huge genetic component. We know from alcohol it's 60 or 70%. My typical patient who takes Vicodin, if you took Vicodin, the common commentary is it sort of made me sick and I really don't like it. But someone with a genetic predisposition, when they come to my office, I'll say, please don't tell me. Let me tell you how you felt. They feel on top of the world. They feel like this is the way human beings feel. It is a different sensation than people who aren't genetically predisposed. The takeaway here, I know we have no time, there's always help, always help. All you have to do is reach out and help and ask for it.
So stop digging, look up, and look for help.
Yep, and there is always help there.
That
you just got to ask.
What is, in 30 seconds, what is the best part of your job that you do, your passion?
You know, the best job is when I can get people to go from I have no problems to I'm willing to do whatever you ask me to do because I don't want to live this way anymore. Sweet. That is just the best.
Right. All right. Dr. Baker, you're something else.
Nice to see you, Liz. Thank you so much.
This was just lovely. All right. Dr. Baker, Dr. Bruce Baker, the, say again, the Westbrook Recovery Center.com. Go to it. Check it out. Check out the web. You know what he thinks. You know how important all of this is. Again, stop digging. Look up. Look for help. Look for the hand of help. Just tell me, think about it, and tell me, what do you think?
You're good.